I would like to start by introducing Dr. Anthony Killeen, who is the director of the clinical laboratories at the University of Minnesota Medical Center. He is also director of clinical laboratories for the entire Fairview organization and vice chair of clinical affairs in the Department of the Laboratory Medicine and Pathology. He has a tremendous knowledge about all the aspects related to compliance in laboratory and medical practice. He is also the chair of the College of American Pathologists Committee on Laboratory Accuracy Surveys, right? And Instrumentation Research Committee. And this committee actually monitors the quality of the laboratory assays across the country through the distribution, collection, and analysis of proficiency testing specimens and brings problems it identifies to the attention of the clinical pathology community. So please welcome Dr. Tony Killeen. Thank you.
Well, thanks, Emil, for that kind introduction, and good morning, everybody. It's great to see old friends, many old friends here this morning that I haven't seen in quite a while. In fact, I think some even pre-COVID. So I'm going to talk today about, the title of my talk is Opportunities and Limitations of Big Data in Lab Medicine and Pathology, and I will relate, as you know, where practical, this concept to compliance issues, because there's a lot of tie-in here. But I think, you know, it's apparent to everybody in this day and age that we're living in the era of big data and huge data sets, and they provide unique opportunities to think about human disease and to think about medicine. But there are also some limitations that, particularly when it comes to lab data, that we as pathologists know about that I think a lot of our clinical colleagues aren't always that familiar with. So let me begin with just the disclosure slide. I have no financial interest to disclose. As Emil pointed out, I work at the University of Minnesota. I have grant support from NIH and CDC, and if I will be mentioning some commercial products in this presentation, but they're not intended in any way to be endorsements, and they're not intended to be criticisms either. I'm just giving you the facts as I see them. So what is big data? First of all, I think it's useful to have some sort of a working definition of what big data is, because it's such a vague term and it can mean so many different things to different people. So I like this particular definition that DeMauro and his colleagues wrote in 2016, because it's got a number of key concepts that are kind of tied together into this one rather lengthy sentence. So big data is the information asset. That's the first thing. It's an information asset. And it's characterized by high volume, velocity, and variety to require specific technology and analytical methods for its transformation into value. So we have this big set of data which is coming at us very fast. It's different types of data, and somehow we've got to have the tools and the wherewithal to take that information and extract some useful information out of it. And that's kind of, I like this definition of big data. So these are some of the characteristics of big data in healthcare generally. So first of all, as I think we're all familiar with, hospitals generate, and clinics, labs generate huge amounts of data every single day. These come from very diverse sources, and they come in different formats. So they can be, for example, patient narratives about what they're feeling, what their medical history is, what their family history is, and so forth. Clinician reports, lab reports, imaging reports. They come in different formats, very diverse formats. They might be clinical notes, written, handwritten, or typed in notes, numerical test results, genetic sequences, images, physical sensor data like from cardiac monitors, blood pressure devices, and so forth, insulin monitors, glucose monitors, drug dosing regimens, and so forth. There's a lot of different types of data that end up in the medical record, and frequently these are often unstructured in the sense that they don't come in neat little bundles every time, and every patient's note is the same format. That's not always the case. In lab data, we obviously also have diverse sources, types, and information content. So we have numerical values, such as the quantitative results that we produce every day from our chemistry, hematology analyzers. These are purely numbers that come out of the instruments. There are categorical data, such as nominal results, like the names of infectious organisms, HLA, blood types. Those are nominal types of data. Ordinal results, where you have strength of immunostaining as a 1+, 2+, where 2+ is more than 1+, but how much different it is not exactly clear. images again from anatomic pathology, electrophoretic scans. And there's a lot of information that we generate in the lab that doesn't make its way into the patient chart, which nevertheless is important data to think about. And that is the quality data that comes out of the instrument. So every time we run our chemistry panels, our hematology panels, and so forth, there's always quality control information that comes out of the instrument at the same time. And that information is usually retained in the lab, but rarely, if ever, makes it into the patient chart. And the patient chart rarely describes fundamental things like what was the analytical principle for that creatinine result? Was it a Jaffe method? Was it an enzymatic method? Those kinds of information typically do not end up in the report, patient's report, but they live in the lab information system somewhere. Age and location defined reference intervals. So by location defined, I mean in the pediatric units there will be typically different reference intervals than we would see in the adult units. And there's this important concept, and this is where I think pathologists have insight that clinicians don't, and that is there's the lack of exchangeability very frequently between hospitals because of biases between different methods, different test method procedures. And we'll talk about this in more detail. So I had 35 minutes to talk about big data in pathology. It's a huge field. I can't possibly cover the whole thing in 35 minutes. The topics in red I'm going to sort of highlight, but I want to give you a sense that there's a whole bunch of areas where people are currently using big data and exploring big data and where big data is coming into play. So I will talk about big data as an alternative to clinical trials. We'll talk about predictive diagnostics and personalized medicine. I'll give you an example of an important paper that came out in that area. To the compliance issues, we'll talk about quality control and reference intervals and how you can use big data to establish those and to monitor quality a little bit better than our standard statistical process control mechanisms. Areas I will not talk about, but I just mentioned here, clinical decision support systems, so providing information to clinicians in real time about what might be the best test to order, operational efficiencies, monitoring, for example, test utilization practices and giving clinicians feedback on are they using tests appropriately, which tests are they over-ordering, maybe which tests are they under-ordering. In the broader scheme of things, public health surveillance and disease outbreak monitoring. Genomics and precision oncology is obviously a huge field, and we're going to hear more about that today, linking specific genetic mutations with impact on the diagnosis or the prognosis of patients with certain types of tumors, and then improvement in patient engagement and education through big data and making information available to patients over the web typically. So let me start with this issue of clinical trials versus real-world big data, because these are now being held up more and more as sort of competing entities and competing ways of gaining information about clinical practice. So currently, the randomized clinical trial is considered to be the gold standard approach to answering many medical questions. And a clinical trial, a randomized clinical trial, has a number of critical elements which make them successful and make them so valuable and make them so highly regarded. First of all, there's a pre-specified trial protocol, including participant eligibility. Who can enter your trial? Who's excluded from your trial? It may be based on age, maybe based on absence of certain diseases. If you have a clinical trial, for example, you may not want to recruit individuals who've got cancer, assuming it's not a cancer trial, right? Because they may not survive very long for the duration of the trial. Randomization of participants is a key element in the clinical trial because that should balance out any confounding factors between an intervention group and the treatment group. And so people argue which is the more important component of a clinical trial that makes them so good. Is it the trial protocol or is it the randomization? And both are obviously critical. There's careful data entry and data management because people are paying for these clinical trials and they hire people to work at coordinating centers who gather data and curate it very carefully. They're performed under ideal conditions. Patients are followed up carefully by phone call. They don't show up for a clinic visit. They are, however, very expensive to perform. So we have a clinical trials lab here at the University of Minnesota. It's called ARTL, the Advanced Research and Diagnostic Lab. It's over on the west side of 35W. And it's a lab that only does testing. It's a bona fide, CLIA certified, New York certified clinical lab that does testing, but it only does testing for individuals who are enrolled in clinical trials or who are enrolled in epidemiologic studies. So it's a big lab, it's a very busy lab, and it's a fantastic lab to be involved with. So one of the trials that we were involved with was a trial called the SPRINT hypertension trial. And SPRINT asked the question, in people who've got hypertension, does it matter if you lower their blood pressure to 140 systolic or 120 systolic? Back in 2009, 2010, when the trial began, that was an open question, and people didn't know what the answer was. The thinking at the time was the target blood pressure goal is no more than 140 systolic blood pressure. So the NIH ran this trial, and it cost $70 million to run a trial that included 9,400 participants. And I'm not going to talk about the SPRINT trial in detail, but if you're curious, the answer was that the people at the 120 millimeter target goal did better in terms of lower cardiovascular and stroke risk. So the trials can be very expensive to run. So the question that comes up with big data is, can we use real world or big data in place of a clinical trial to answer questions like what's the optimal systolic blood pressure target goal? So the idea here is that you use existing clinical data sets. There are no additional costs to anybody apart from the cost of actually doing the data analysis itself. You're not recruiting people for this, you're simply taking existing clinical data, and you look at people who were treated to 120, look at people who were treated to 140, or who ended up 120 and 140, and see which of these groups of people did better. That's conceptually how you would go about running a trial like that, or running a real-world data alternative to a trial. So you gather large amounts of data. Now, there are some significant downsides to using this approach, of course. These data are not produced, and they're not recorded like a trial protocol. So very frequently, one of the most important gaps in these kinds of studies is missing or erroneous data. So not everybody comes in and has their blood pressure checked every 3 or 6 months, as would happen, for example, in the SPRINT hypertension trial. But it may be possible to use imputation to determine or to estimate what would have been the patient's potassium or the patient's sodium at other time intervals, given that you have some measurements along the way. So that's a statistical approach known as imputation. And there may be also differences in practices between clinical sites. So not everybody who comes to one hospital and sees a group of cardiologists may get the same treatment as somebody who goes to a different hospital and sees a different group of cardiologists. So there can be some heterogeneity in terms of the standard of clinical practice between sites. These are things that make real-world data difficult to deal with, because there's not homogeneity as you would see in a clinical trial, where you have that protocol where everybody follows the trial protocol. So to give you an example, there's this paper, which I think is almost a landmark paper. It's written by Revisa back in 2019. And the study looked at the ability to predict chronic kidney disease from real-world data. So this is a study that was organized by IBM, Roche, and I think it's not Roche's clinical diagnostics division, but Roche Pharmaceutical Company division. Eli Lilly, which of course is a drug manufacturer, and Indiana Biosciences Research Institute, which is a research organization, I assume based in Indiana. I don't know much more about it. What they did was they took data from 418,000 patients with new type 1 diabetes and type 2 diabetes. Now let me pause right there for a second. 418,000 people, right? This is an enormous data set. There is no way that we could ever possibly afford to run a clinical trial with 418,000 participants. The SPRINT hypertension trial, which cost $70 million, had 9,400. So a fraction of this. So an enormous data set. So where do they get this data? From hospitals and from this research institute that were gathering information. So 418,000 patients with newly diagnosed type 1 or type 2 diabetes. The data analysis began, they started looking back 2 years before these patients actually had a formal diagnosis of diabetes, and they looked forward 3 years after the time of the diagnosis. And the question was, can we predict which of these new diabetic patients is going to go on and develop chronic kidney disease? So the predictors that they used, and these were not just chosen randomly, but these were chosen based on medical knowledge and some prior knowledge from other studies: age, body mass index, EGFR, creatinine. I'm not sure why they had both EGFR and creatinine, since those are highly correlated, albumin, glucose, and A1C. And they used what in the statistical world is a fairly basic methodology, which is a logistic regression analysis. It's not one of these black box machine learning algorithms that nobody understands how it works, and nobody can really explain the data when it comes out. They use a simple logistic regression model and a standard machine learning approach with train, test, and validation data sets. And what the finding of this study was, and it's shown in it's the Roche IBM group here, was that the area under the curve, which is a measure of how successful the model is at predicting development of chronic kidney disease was, let's say, about 0.8 in the validation data sets. Now, the 4 studies below that are all clinical trials. Those are all based on those are data from prior clinical trials, prior to this Roche IBM study. And what you see is that the Roche IBM study surpasses, in terms of its area under the curve, all of the 4 formal, expensive clinical trials that had been run to ask the same question, which is which patients with newly diagnosed type 1 or type 2 diabetes will go on and develop chronic kidney disease. So it surpassed the ability of formal clinical trials. So the use of existing clinical data, big data, real-world data, allowed for the development of a prediction model, even using logistic regression, which is not the most sophisticated machine learning technique that's available, that was superior to models from clinical trials in predicting development of CKD. So this was really a very significant, almost a landmark paper. And the authors, one of the authors' conclusions of this was that the findings may fuel the fundamental debate on the future of medical evidence, in that the explorative analysis and interpretation of data beyond the original goals of the underlying costly, long-lasting clinical trials on a limited number of patients may one day be augmented, or in specific cases, even partly replaced by real-world data-driven risk assessment. So this is this is staking, a big statement in the ground about the importance of real-world data and what can be obtained from real-world data in comparison to clinical trials. Are clinical trials going to go away? Not at all. But it is important to bear in mind that you can do a lot of stuff using large data sets that exist already. So I work at the University of Minnesota. We're part of the mHealth Fairview system. We have 4 or 5 hospitals, a bunch of clinics. There is a ton of clinical data that exists in our system. I'm sure many of you work in similar systems as well, where the data is out there and it's a matter of extracting the data, getting useful data, and being able to interpret it correctly. Now, the governments around the world have paid attention to this real-world evidence, real-world data issue. And in fact, this is not in the context so much of clinical trials, which is the better blood pressure goal to meet, but in terms of drug efficacy and perhaps new uses of drugs. The FDA actually has guidance on when they will accept real-world data. The European Union has written a similar document, and the Chinese National Medical Products Administration also has a document that outlines. So all of these major regulatory bodies around the world have written documents that outline under what circumstances and what conditions will they consider real-world data in lieu of a clinical trial. So it's a field that's moving in that direction. Now, I said I would talk about some of the limitations as well. So let me talk about this important issue here. And again, this is where we as pathologists have insight into something that our clinical colleagues, and frequently even people in large pharmaceutical companies, I think do not have. So not every test that comes out of my lab is going to give the same result as it would if it came out of another hospital in this city, if given the same patient sample. There are differences between labs, there are differences between methods. And this issue of lack of harmonization or lack of standardization between different manufacturers' test results remains a very significant issue in laboratory medicine. And it's a practical limitation to aggregating real-world data. So you just can't take every lab's information and just bundle it together because of these differences between measurement procedures. And there's a bunch of societies around the world that are working on trying to fix this problem. Ultimately, it's something that the manufacturers have to fix. But let me show you an example. This is an old slide. This is from 20 years ago. So this is a measurement of a creatinine sample in a normal human serum sample. So they made a pooled human serum sample and they sent it around to a bunch of different labs, and they asked them simply to measure creatinine. This was a study that was done and reported back in 2005. And there was a reference method value assignment to the sample. So the sample was sent to a higher quality reference lab that was performing reference testing for creatinine, and they gave us the true value of the creatinine concentration using isotope dilution mass spec. And what we're seeing here are the biases between the true value and different manufacturers' equipment. So if there's no bias, the results would be on the 0 axis, on the 0 line. And what you're seeing is that in the majority of cases, there are significant positive biases. In other words, the creatinine was being overestimated relative to truth by the majority of different manufacturers' instruments out there. And there was one instrument, and this is the Toshiba, the one in the red bar there, that was over 0.3 milligrams per deciliter high. Now, the concentration of the sample, being a normal sample, is about 0.9 That's about a normal creatinine concentration. So this is like 30% higher. 30% higher. Now, what impact would it have if you were a patient and you were having your creatinine measured on that Toshiba instrument? It's going to come back, we assume, because this is a normal human serum sample, we assume all patient samples will be affected similarly. It's going to come back high, which means your estimated glomerular filtration rate is going to look low by roughly 30%. So this would have a huge impact on patient care. So a lot of effort went into, over the last 20 years, into standardizing creatinine. NIST produced a standard reference material. The isotope dilution mass spec, tandem mass spec methodology was accepted as the definitive reference method procedure. And so things have improved. At least that's what we were thinking. So let me tell you about a more recent study, which is the CAP's linearity survey. So the linearity surveys are intended to provide samples that allow a lab to determine the range of linearity of its measurement procedures. And you can measure results that are within the linear range. If they're above, if samples have concentrations above the linear range, you have to dilute to bring it into the linear range. That's sort of fundamental thinking, is you don't run samples outside of the linear range. So the LN24 survey for creatinine is somewhat unusual in that it uses, again, human serum that's been pooled. So this is not like most proficiency testing material, which is completely artificial. The way most proficiency testing material is produced is they start out with pooled serum, but then they pass it over activated charcoal to remove everything. Activated charcoal is like a vacuum cleaner. I mean, it just sucks everything up out of the solution, and then they can start adding analytes back as needed to achieve target concentrations for the PT survey, because PT surveys have to challenge at low, mid, and high concentrations of various analytes. Level 1 of this material is unadulterated, so it's just the basic pooled human serum. Level 6, not sure why that's advancing, level 6 is spiked with pure crystalline creatinine, and then the levels 2 through 5 are made by admixtures of level 1 and level 6. And this stuff has been shown to be commutable with human serum. So this sample, we're going to look at the base concentration sample. That's the level 1, which has not had any adulteration. That was sent to 274 labs around the world in this particular mailing of the survey. These are the manufacturers. And they're the typical manufacturers that you would see for chemistry systems. There's about 8 to 10 large chemistry manufacturers, clinical chemistry manufacturers throughout the world. So we got Abbott, we have Beckman, Roche, Siemens, and Vitros. Vitros is Ortho Quidel, Ortho Clinical Diagnostics. And you can see the majority of the participants were using Roche equipment, followed by Beckman equipment. Now, when we look at the results that they returned, this is what the plot looks like. Now, this is from the CAPs, this is in micromoles per liter, but that 80 is roughly 0.9. That's sort of the normal concentration. And the target value for this particular sample is shown by that broken or that dashed horizontal line. That's the true value as determined by a reference lab. So what you see is that different manufacturers, and they're color-coded for you, so Abbott is in blue, Beckman is in pink, and so forth. Different manufacturers give slightly different values of measurement for this creatinine sample. And if you start with the Roche as a comparator, then the Abbott method and the Beckman and the Siemens method are all statistically different from Roche. Okay, so that's one thing that's a little bit concerning here. And this is a fairly simple measurand or analyte that has been well standardized, well characterized over the years. And we still see these kinds of statistical differences between them. When we turn to the methodology that's involved, the differences become even more dramatic. So in blue are enzymatic methods, and I've grouped them by manufacturer. So the first two are Abbott, the second two are Beckman, third is another group, it's a small group. Randox doesn't have a Jaffe method, so it's just shown in blue. Roche, Siemens has both methods, and then Vitros only offers an enzymatic creatinine method. And again, what you see are these fairly consistent differences in that Jaffe methods still tend to run somewhat higher than enzymatic-based creatinine methods. And in fact, the Jaffe methods look more similar to each other across manufacturers than do Jaffe and enzymatic within manufacturers, which is kind of surprising because you would think that manufacturers would standardize their assays so they'd all be in agreement. So in almost all cases, so for Abbott, Beckman, and Siemens, the Jaffe results are higher. The outlier here actually is the Roche assays, where the Jaffe results are slightly lower than the enzymatic and statistically different from the enzymatic. Okay. And then the other issue, so even within a manufacturer, we have to still deal with this issue of reagent lot-to-lot differences. So if you look at the left panel here, what we're looking at is glucose measurements over time with a human serum sample, a pooled human serum sample. This is actually data from our ARTL lab that I prepared. So each one of those colors represents a new lot number of reagents for measuring glucose. And you can see, I don't have a pointer here. Does that show up? I'm not sure how I get the pointer to... let's see here, laser pointer. Does that show up? Yeah, okay, good. Okay, so here we have this lot in purple and this lot in brown. And we're running, I don't know if you can see the number here, but we're running somewhere typically below 100 milligrams per deciliter glucose concentration. So in this reagent lot, the value went up to about 102, 103. This reagent lot, it went down to about 97 or something like that. There's about a 5 milligram per difference in the readout of this human serum sample between two different lots of glucose reagent. That is unacceptable. And that also, by the way, clinically, that crosses an important threshold because 100 is the beginning of impaired fasting glucose. If your fasting glucose is 100 or more, then that's not normal. So this lot-to-lot variation here, this lot would have made more people have high glucose, and this one would have brought it down lower. But the whole thing is like, this change here is beyond acceptable limits, in my view. It's beyond what we should be accepting clinically. This panel here shows the same thing for a high concentration pool. This is the normal concentration pool, the high concentration pool. So what does this mean? It means that from a compliance point of view, is that we're in compliance and that we're using FDA. These are all FDA approved methodologies. But from a clinical perspective, we're seeing these differences that are attributable to differences in reagents and reagent lot numbers between, lot to lot within this single manufacturer. So this is something that you need to be aware of. And I don't know, and I haven't quite thought through what the legal implications of this would be, but certainly this could have impact on diagnoses, that some people would either be abnormally called as having a disease. If, for example, if this was around the diabetes diagnosis threshold of 126, some people would have been called diabetic and some people would not have been called diabetic, depending on the time when their sample was measured. So these are the kinds of things to be aware of. And there's very little in the lab that we can do about lot-to-lot variability because we buy reagent lots from manufacturers, and it's not like you can tell them, well, I don't like this lot, give me a new lot. They don't have a new lot. This is the new lot. They don't have like a backup supply of different lot numbers that you can just ask for. Okay, so that's one issue, the clinical trial, real-world data thing, and then I've shown you some practical complications of aggregating data between different manufacturers and even within a manufacturer over different times because of lot-to-lot variability. The next thing I want to talk about is establishment of reference intervals. So we are required by CLIA to establish reference intervals for all of the tests that we offer. And there are typically two main approaches to establishing reference intervals. One is the direct approach, which is where we recruit healthy donors and we take blood from them and we measure whatever we're interested in and we establish a reference interval. Typically it will be the central 95%, assuming it's a normal distribution of results. The other way of doing this is the indirect. Now this gets back to the big data thing, where we can take data from medical records and extract what we think would be the reference interval from large data sets of patient results. So again, there are some advantages and there are some disadvantages to using indirect reference methods, but they are being used increasingly frequently. The obvious one is that the data already exists. You don't have to go out and recruit donors. Particularly, this is nice if you're dealing with pediatric populations where it's really hard to recruit healthy children to be participants in reference interval studies. The other trouble with this is that there is heterogeneity. So all of our lab results don't come from healthy people. I mean, almost by definition, a lot of our lab results come from people who are sick. But it's possible to kind of isolate a relatively healthy population, for example, outpatients who are just having an annual visit, people who are having preoperative blood draws or blood work for elective surgeries, like somebody having a hernia repair, or you can imagine some other surgeries where the patient is basically healthy. So if you can sort of focus your results or focus your data extraction on those kinds of people, then you're off to a better start than if you would never want to recruit people from the ICU for this kind of study. So the idea behind indirect reference interval estimations is that here we have this whole set of data that we've extracted from the medical record, and some of these are healthy people for this particular analyte, and some of them are diseased people. And how do we find the healthy people? So this falls down to a statistical approach, and there are some approaches that have been used in the literature over the years. Going back to 1963, there was a paper by Hoffman in 63, Bhattacharya in 1970. There's a technique called truncated minimum chi-squared, and now most people are using this refiner package, which is a package in the R statistical software program. But basically the idea is that you take all of this data and you do an analysis and you try and find out where is this sort of normal or Gaussian distribution sitting in the middle of the data, and you focus on that and you set plus or minus 2 standard deviations, and that would sort of be your approach to identifying a reference interval based on this very heterogeneous set of results from your patient records. So can you use this from a compliance point of view in the United States? Yes, you can do this. This is absolutely an acceptable way of doing it. The CLSI accepts this. In fact, there's a CLSI document that's coming out, or at least a new version of a document that's coming out in the next, hopefully in the next 6 months, not more than a year, that will describe how to do reference interval studies. One of the things they're going to allow is the use of indirect reference intervals. So this is absolutely perfectly fine to do. But you just have to understand the limitations of doing this and understand the data set that you're getting your stuff from. Okay, reference interval harmonization. So we're in a large, as I said, I'm working in a large medical system with multiple hospitals. I'm sure others of you are as well. Can we have common reference intervals across our whole system? Can we have reference intervals that are common across the whole state of Minnesota? So the idea here is that if analytical methods agree reasonably well, then the reference interval should also agree. And we all know that clinicians commonly rely on reference intervals to determine if a test result is normal or not. So there have been several initiatives around the world with the goal of harmonizing reference intervals. There's the Nordic Reference Interval Project, the UK Pathology Harmonization Project, Australian group, there's a Canadian group. And I'm going to talk particularly about the study that was published in Clinical Chemistry just about a year ago, a little over a year ago now, by Bone. So this is out of Canada. What they did was they analyzed outpatient lab data from 4 labs across Canada for 16 chemistry tests over 2 years. So the 2-year period was January 2017 to December 2018. They chose labs that covered several provinces and at least 2 to 3 methods per analyte. Methods meaning like a Siemens method, a Roche method, Abbott method, so forth. Adults of that age, they collected age, gender, data collection, they dropped duplicates. They were interested in this panel of tests, which are listed for you here. These are common clinical chemistry tests that we perform by the hundreds, if not thousands, every day of the week. And they use the indirect reference interval determinations using the refiner package. That's our statistical software package that I mentioned for you. And I think I can sort of maybe skip over this slide in the interest of time. But let me get to this one here. This is alkaline phosphatase. And so here we have results from an ADVIA system in Alberta, a COBOS in British Columbia, another COBOS in Ontario, a second COBOS in Ontario. And what they found basically was that there were no differences, statistical differences for alkaline phosphatase across these different labs in these provinces. They were reasonably close together. And so based on this, they were able to come up with reference intervals based on gender and age, which are shown here. Again, the point I wanted to emphasize, though, is this data that I've shown here in red. If you sum all of the numbers in these first 4 columns, this is the total, you get 4.8 million patient results. 4.8 million. I mean, this is absolutely an enormous number. So a typical reference, how many would we do for a reference interval study here in the US in clinical chemistry? If you were to get a new instrument in your lab, how many people would you recruit? 20, yeah, we'd do 20, right? They have 4.8 million, okay? So, I mean, just to put this in the scale, if you were a manufacturer here in the United States, you'd have to do maybe 120 if you were developing a method de novo. But 4.8 million, so absolutely huge. So basically, I'll summarize this quickly because I'm running out of time here. For most of those clinical chemistry analytes, there was reasonable harmonization of the methodology, and they were able to come up with reference intervals that were common. There was one exception, namely free thyroxine, which differed significantly. So, for example, the Alberta lab gave higher values than the British Columbia lab, and you can read the rest there for yourself. And some of the upper and lower reference intervals were just too different in order for them to feel that they could aggregate all of this, so they left it at that. So that's kind of the gist of that. Quality control. There's this technique called patient-based real-time quality control. So in addition to running regular quality control samples that we measure every shift or every 8 hours or whatever your schedule happens to be, there's this thinking that we can take patient moving averages, again, focusing on patients we believe are relatively normal. That would be to say outpatients and people having elective surgery, but sometimes it's hard to tease all of this out. But the idea is that you take a window of time, let's say a minute, 5 minutes, 10 minutes, whatever frequency of testing you're doing determines this, and you take for that window of time, you take the average, right, of that, all the patients who are measured then. Then you move a minute and you take another group. Now some of these patients are going to overlap between groups because this is a moving average and we're moving every 10 minutes. So somebody will fall off. So somebody will join, and somebody's result who was measured earlier will fall off. But there's this moving average that's taken constantly. That should be relatively stable over time. That's the theory behind patient-based reference intervals or quality control. And this is available. So currently we're using Roche equipment, and they offer this through their Navify system. They already have the software built for you, and we're looking at implementing this at the university hospital, and if it works there, we'll recommend rolling it out. There are some issues around this approach. How far, if you have methods that are very close, where patient values don't differ a lot, this is, for example, sodium, you don't have to have a whole bunch of outliers before you see a significant change that would flag there's something gone wrong with my assay. If you're looking at ESRs, erythrocyte sedimentation rates, those values differ wildly across patients, so you have to have a huge number of outliers before you'll pick up something abnormal. But this is a new approach that is in addition to standard statistical process quality control with Levi-Jennings plots and so on that we're all familiar with. So to summarize, big data has many applications in pathology, including in alternative clinical trials, establishing reference intervals, quality control. These all have compliance, and you are allowed to use all of these these are legitimate techniques to use from a compliance point of view, establishing reference interval. The limitation is that the data is typically collected for clinical purposes and not for research. So in the clinical trial arena, there's often missing data that you have to deal with. There can be other issues such as consent and privacy, and it does require pretty specialized analysis. So I'm sorry I ran a minute or two over time. I will stop there, and thank you for your attention.
Claudia.
Tony, thank you for a really interesting talk. Is there any suggestion of following the model of coag assays and introducing an INR to normalize?
So that has been proposed for some tests that we would establish, each lab would establish a sort of a reference interval, and you'd express patient results as a fraction of that reference interval. And there was a guy in Arizona named, I think his last name was Blick, B-L-I-C-K, and he came up with what he suggested was the Blick index, which was based on exactly that idea. And he proposed this to the college. He said the college should promote the Blick index, which was named after himself. And we said, no. A lot more theoretical and practical work needed to be done. But yes, people have said, rather than having a reference interval with numerical values, we'll express it as, well, they still have numerical, but it will be a percentage of where is this patient as a percentage of the reference interval in my lab. But that idea has been proposed. But it hasn't really taken off at this point.
John?
Tony, thank you so much. I really enjoyed that talk. Some people may not like what I'm going to say, but I'm going to say it anyway. The electronic medical record has been very important in the progress of medicine in this country. But I think that pathology and medicine as a whole failed in their responsibility in the development of the electronic medical record. The electronic medical record had much more input from billing offices and hospitals than it did from patients and physicians, who really should have had a lot more input into the development of the electronic medical record. And as you point out, other countries have done a much better job than we have. Your comments?
Yeah, I agree with you completely. In fact, the reason everybody was pushed into using programs like Epic, which is probably the dominant one in this country, is for billing purposes, because the government said, well, we're getting overbilled, we're getting overcharged, we're not getting accurate CPT coding, so we're going to make everybody record everything in CPT documented. And you're right, it was driven by billing purposes. Then they roll it out. We all spend $1 billion per hospital or something. I mean, it's an extraordinary number to buy Epic. And then guess what? The billings actually went up because people started to truly document what they were doing. Previously, they hadn't been charging for everything that was being done because they themselves were not documenting it. So when everything was better documented, suddenly it turned out the payers owed us more money. So it was like a lose-lose situation. I mean, there are advantages to the medical record as opposed to I'm old enough to remember the old paper charts, right? I mean, they were a total disaster in many ways, where lab results would be literally stuck in with Scotch tape or something like that. I mean, it was just craziness, but it has numerous problems. Andy? Oh, I'm sorry. Sorry, Delhi.
Oh, yeah, mine is more of a quick comment than a question. So thank you for a nice presentation. I think the clinical labs have been dealing with this intra-lab and inter-lab variation in normal for many years. So you're probably, I'm not sure if you are getting to the end of fixing the problem, probably not. But in surgical pathology, I think this is becoming our reality going into the future. So when we look at immunohistochemistry and special stains, in the past, it's either positive or negative. So we didn't interpret things based on the intensity of staining, right? Then we went into the realm of predictive and prognostic testing, and then it starts to matter how much R2 new there is and everything. But for the most part, each lab has been able to validate, and the proficiency testing has shown some comparability. Now we are going into the era of AI, and I'm sure we're going to be hearing more about that. And I think that's when it's really going to matter. So in our lab, we just finished validating new set of stainers, and it's just incredible how different the staining quality, where we had to go through like Congo Ref for 4 or 5 times before we could get the intensity, and you had to change the protocol completely.
Yep.
So when I'm looking at it with my eyes, that's fine. But I think when we get into the era of AI, we're going to have to start dealing with what you just described, because this AI, all the IMS are using different algorithms. And even when you validate it on one instrument, how transferable would that be when I bring it to my own lab? Yeah. And then when I change my stainer, how often do I have to retrain the? So I think it's something that the surgical pathologists, as exciting as AI is, it's also one of those challenges that we need to start braving up for.
Yeah, I agree with you completely. I mean, you look at creatinine. I mean, creatinine took 5 years. Creatinine is a simple molecule. And their reference methods, procedures, reference material, it took 5 years to get manufacturers to agree. You start looking at endocrine, like some peptide hormones and stuff, like HCG, beta HCG. There's so many isoforms of H. What are we even measuring? What are we supposed to be measuring here? So there's many decades. Those of you who are, oh, by the way, I will say, because I know there's some residents here today, is I do think it's important for residency programs, and I'm sorry, I'm taking time here. I'll make a quick comment here, to get our residents trained in how to analyze large data sets. I think that's a really important component of any kind of training, but especially lab training these days. I'll stop there. Okay, thanks.